My talk today, I have really chosen the subject of updates on prognostic and predictive markers of breast cancer, specifically in the digital era that we're living in today. The fact that digital pathology, deep learning, and artificial intelligence play a major role in pathology today. So artificial intelligence is not the science of tomorrow, but it's the science of today. And because I have only 20 minutes to go through my talk, so I better move on to conflict of interest. And this is the outline of my talk. I'll take you through it. First of all, I'll talk about the predictive markers. Most importantly, PD-L1, ER, low, and HER2 low. These are new rules in old parameters. The parameters, we know them quite a long time ago, but now a change has been added to their definition and expression. Then I move to some prognostic markers and the difficulty that we face as pathologists in the lab in trying to implement these new rules in these new parameters. Lastly, I will tell you how digital pathology and artificial intelligence can help us solve these contradictive issues. So I'll begin with the predictive markers. PD-L1. PD-L1, we use it by immunohistochemistry. It's a monoclonal antibody, and it's supposedly given in recurrent or late cases with or without combination chemotherapy. Now, in 2021, there was a very famous accelerated given therapeutic protocol, but it was called the clone of SP142. Gained some famous reactions, however, it was withdrawn and it was then replaced by the other clone, which is the clone 22CF3. These are really important messages that I give today because it's important to use the proper monoclone for the proper test. And it is now an approved therapy for immunotherapy protocol. Now, how do we then measure the PD-L1? We have a complicated scoring method in which we count all the cells that are positive for the immune reaction of PD-L1, namely the lymphocytes, the macrophages, as well as the tumor cells. It's not really important to differentiate at that stage, but we count them collectively, and that is why it is called combined positive score. The number of positive cells will then be multiplied by 100 and divided by the total number of viable tumor cells. And here viability is very important. We do not include inflammatory reaction, and that's again an important issue that we have to consider. Now, then the result will be subdivided into positive or negative. However, for clinical implications, we only consider the case positive, that is amenable to immune therapy, only if the combined positive score is 10 or more. So we count the cells, multiply by 100, and then divide by the number of viable tumor cells. For that, I'm going to introduce a very small pilot study that we done using the PD-L1 in triple-negative breast cancer. The scoring as follows: it's either negative or positive, and the sample is adequate only if 100 tumor cells are present. And here, this is a very clear message to oncologists and our colleagues, the radiologists and the clinicians involved, that we should be having adequate material, which is very, very important. Now, the result that we found, about 20% of our cases are positive for PD-L1 reactivity, and this is a photo microgram of a case of positivity with a combined positive score of 17, so it's more than 10, so it's positive. However, and I will say a lot of howevers in my speech now, in the same tumor, you could find an area that is totally negative. And why is that? Why would a part be positive and the other is negative? And that is because of the very famous phenomenon in cancer tumors, the heterogeneity of any tumor. You will not find the same reaction all over. Again, this is one other case which showed two different fields, one with few positive lymphocytes, but the other with many positive cells, including tumor cells. So how do we count them? Do we count the less populated area, or the hotspots as we call it? And this is really a problem for us. Or we can do what is supposedly to be done, which is to scrape the whole slide, which is called the whole slide irrigation. We also found that the PD-L1 is more positive in younger females, that is, females younger than 40 years. And this is a case that was positive in a female, which is 36 years, she's supposedly young, and this is a highly positive case for PD-L1. So the difficulty that we're showing is that tumor heterogeneity really is a problem to us. We have to score as much cells as possible, more than 1,000 cells or so, and that is really over the capacity. This is the first marker that I talked about. Now I move to another yet new rule in an old parameter, namely what is called ER low. Now the ER positive and the ER negative are well known to us. However, a new terminology now emerged saying that a tumor with less number of ER positive cells is called ER low. And here, when the cells are only from 1 to 10% positivity of ER expression. The intensity here is not important, however, it is usually of low intensity. So what about the overall benefit of endocrine therapy? These patients that have low level of ER positivity. Again, we go back to the problem of tumor heterogeneity. They are a heterogeneous group, both in behavior and biology, and they often have the gene expression profile like similar to ER negative cancer. So not related more to the ER positive, but related to the ER negative. And here, a multitude of studies showing that the ER low is now consisting about 2 to 3 or maybe maximally 5% in many of the series, contradistinction to the ER positive, 85%, and the ER negative, 15%. So although there are a small amount of patients or cases, we do come across them now, and we consider to really count them particularly important. What about the biology of this type of tumor? As we see, the ER low, they are different biologically from the ER high. Namely, that the ER low is more towards the basal phenotype with less luminal A and B versus the ER positive or high, which is oppositely high in luminal A and B phenotype and very low on basal parameters. So we really think that these are two different diseases, and again, different from ER negative altogether. We look at these photos that might perplex us in the lab. The negative is clear cut and the positive is clear cut, but we have an intermediary where we can, ask ourselves, is this positive? Is this 1%? Is this more than 10%? I could say it's low. Dr. Rana could call it high, whatever. This is due to the subjectivity of the human eye. We are not machines. Again, another problem that can face us is the prompt tissue fixation. As the tissue is outside the body and not properly fixed, it loses the antigenicity and the immune histochemical reaction. The longer the time, the more it will be destroyed or devaluated. So much so that ER weakly positive would then become totally negative if not properly fixed, or a strongly positive can become weakly positive also due to the inadequate prompt fixation. So here is a word to you that we should have properly fixed tissues and adequate material for the reasons we just showed. Another point of interest is the DCIS. The DCIS is separate from the invasive component. We can have cases positive for ER in the DCIS component and not in the invasive component. Moreover, the DCIS can also be heterogeneous in a way that some of them may be ER strongly positive while others are negative. And when we have a DCIS component in an invasive component, we do not really mention it much because it has no impact. However, if the tumor is solidly DCIS, then we have to look for the positive areas and the negative areas and consider which one stronger. Here, it's always said that it is called multiclonal and not heterogeneous. It's multiclonal. It's as if the patient is having two different diseases, but the prognosis will be governed by the more aggressive one, that is the ER negative. So multiclonality of the estrogen receptor in ductal carcinoma in situ is now very well known, and it is rather prognostic rather than predictive. Now, HER2 low. HER2 low breast cancer is again a newly introduced subset of HER2 negative breast cancer. There are two options. Either it could have a score +1 by immunohistochemistry, or a score +2 with negative CISH or FISH. Now, recent clinical trials have demonstrated there is a significant clinical benefit of the anti-HER2 therapy with drug conjugates, ADCs, in treating this group of patients. The trastuzumab TXD. Here again is a borderline reaction. Again, I could say this is +1. Another pathologist would say it is +2 in some areas. And again, going back to the subjectivity of the human eye, and we have to resort to FISH. We wish that we could have strict subdividing categories, but we don't. We have a shady scale of increasing percentages so that we do not really have a distinct cutoff values in the area where the tumor is from 1% up to 10%. And we have to segregate that from the negative component on one side and the positive tumors on the other. Here, for HER2, we had a 2-tier scoring system, but now we have 3-tier scoring system, and we have to consider this intermediate area of HER2 low. Again, this is one case that could cause problems between pathologists. We are limited by our subjectivity. I could say this is +1, others could say this is non-specific and negative, and many others could say maybe it's +2. So what about the biology of HER2 low? Now, HER2 low, most of them would be related towards the luminal A and the B, and not towards the HER2 plus. So, and again, they are enriched by hormones, but they have a low proliferation index. And therefore, HER2 low is more related to the HER2 negative rather than the HER2 positive. So why are these patients then having advantages of the therapy? Simply because they found that there is enough number of molecules on the cell receptor, maybe up to 100,000 molecules of HER2 on these cells. Of course, the positive cells would have millions, but the low HER2 cells would have 100,000 molecules, giving it the threshold of unique bystander killing effect, and that is why they can benefit from targeted therapy as well. Now we move to prognostic markers. Ki-67 is a great help to all pathologists, and we always use this favorable clone, which is the MEP1. Now, the cutoff for the high risk recurrence is 20%, and thank God that it's been stable for that number for some time now. 20% is the cutoff value, which then can say whether this patient is at high risk for recurrence and thus have adequate therapy or not. Here are cases that all are having 20% or more reactive immunohistochemical reaction for PI67. However, this is maybe a tumor, one tumor that could have those three parameters presented. Some areas would show less than 20%, others may show just about 20%, and some other areas would show very high density positive proliferating cells. We use the process of eyeballing, that is, we just see the impression and record it, or we can use an image analyzer, which is more accurate. We have to count up to 1,000 cells if we want to be sure whether we want to count the hotspots or count the heterogeneous areas, or just do a whole scale for the whole section. And here is where we come and need the help of digital pathology, deep learning, and artificial intelligence. It is a scanner that will convert the photo to a digital image, and hence every spot, micro spot will have its own integral signal to provide. We teach the instrument, and then the instrument will do data manipulation, proper equations, and give a precise decision, especially in those gray zone areas that I just mentioned. And this is an example of a slide scanner that will take a lot of slides at a time, and also scan the whole slide and count more than 1,000 or 5,000 in case here when it becomes an objective means of deciding on the reaction. We have moved a lot to the milestones of computerized pathology, and now in the year 2020 and beyond, we have come to the digital pathology whole slide scanning solution, and it's finally there. So the digital pathology will help us a lot in the gray zones. It will be more objective than our subjectivity. It will really store a lot of digital data sets. Up to millions of cells will be counted, validated by the labs, and putting standardization for each lab. We can use this for consultation cases. We can send the slide to be scanned anywhere in the world, and we can use it in education. And definitely, and most importantly, when a pathologist is sitting in the MDT meeting, he will have precise, very delicate answer to each and individual case. This case is ER low, this case is HER2 low, or otherwise. The quantitative image analyzer is now well established and can read ER, PR2, and KI very quickly and very precisely. Now, artificial intelligence, we can teach the machines to detect mitosis and thus refine the grades. The grade 2 tumor is now being more refined into a low grade 2 and a high grade 2. Lymph node, we could also teach the machine to recognize micrometastasis or even individual solitary metastatic cells. The TILs, which are very important in establishing some prognostic and predictive markers. It is very difficult for us to count the TILs, but we can teach the machine to do it for us, and can predict the molecular expression as well from very simple H&E section. And this is being taught to some machines to do it. In the end, it will reduce pathology workload, not that we do not want to work, but because machines are doing it for us, to improve the diagnostic and the scoring accuracy, reduce human error, and overrules the tumor heterogeneity and hotspots and so forth. the literature is full of references about the present impact of artificial intelligence. And there's nothing really intelligent about artificial intelligence. It's the human intelligence that made us realize how we can use dumb machines to do a better job than us. Thank you.
Thanks, Dr. Nadia. As usual, interesting and comprehensive. Any questions? It will be postponed at the end of the session.
I would like to present Professor Dr. Mona Mamdouh. For the talk, she will talk about update on her two new classification. Thank you.
Update in her two new classification. Estrogen receptor, progesterone receptor, and HER2 are biomarkers which needed for some breast cancer to grow and divide. As part of breast cancer diagnosis, these biomarkers are tested on breast cancer tissue, which act as a predictive and prognostic marker. The results of each biomarker will be reported as positive or negative. According to these biomarkers, breast cancer classified into molecular subtypes. These molecular subtypes tells us what is feeding the breast cancer and determines the types of treatment that cancer is likely to respond, such as hormone blocking medications in case of hormone receptor positivity, monoclonal targeted therapy in case of HER2 positive, and or chemotherapy. Human epidermal growth factor receptor 2 is a membrane tyrosine kinase protein encoded by HER2 gene, which is located on chromosome 17. HER2 signaling promotes cell proliferation via the RAS-MAP pathway. HER2 gene amplification can result in massive overexpression of HER2 cell surface receptors. This is a normal cell show to This is a normal cell show two copy number of HER2 gene with few cell surface receptors. But this is a malignant cell show overexpression of HER2 cell surface receptor due to increased gene copy number. Too many HER2 receptors send more signals, causing a cell to grow too quickly. Breast cancer classified as either positive, HER2 positive or HER2 negative based on protein expression and or gene amplification. HER2 positive is present in 20% of invasive breast cancer. HER2 acts as a predictive and prognostic marker. As HER2 positive breast cancers predict response to HER2 targeted therapy, and they are aggressive tumors with high risk of metastasis and decreased survival compared to HER2 negative breast cancer in case of absence of therapy. ASCO-CAP HER2 testing guideline in breast cancer initially published in 2007, then updated in 2013 and 2018. These guidelines were developed to standardize accurate detection of HER2 gene amplification or protein overexpression in breast cancer for prediction of benefit from HER2 targeted therapy. Recommended methodologies to detect HER2 are immunohistochemistry, which detect protein expression, or in situ hybridization, which detect gene expression. Guidelines of HER2 protein expression detection by immunohistochemistry is the first test that done for HER2 assessment. Results are evaluated based on the percentage of positive cells and the degree of intensity of membranous state. The immunohistochemistry score can be from 0 to 3. HER2 considered negative in case of immunohistochemistry score of 0 or 1. 0 when there is no staining or there is incomplete membrane staining in less than or equal 10% of tumor cells. While immunohistochemistry 1, if there is also incomplete staining of the cell membrane, but in more than 10% of tumor cells. HER2 considered positive when immunohistochemistry is 3. This when there is circumferential membrane staining that is complete and intense in more than 10% of tumor cells. While if there is complete staining, membrane staining observed also in more than 10% of tumor cells, but is weak to moderate, it's considered as equivocal and scored as immunohistochemistry 2. In this case, reflex in situ hybridization should be done to detect gene amplification. There are other unusual staining patterns of HER2 which are considered as immunohistochemistry 2. For example, intense but incomplete circumferential membrane staining, which occurs in some specific subtypes of breast cancer as micropapillary breast cancer, and intense complete circumferential membrane staining, but within less than 10% of tumor cells. This is score 0, score 1, score 2, and score 3 immunohistochemistry. The ASCO-CAP guidelines of HER2 gene amplification detected by in situ hybridization, which may be fluorescent in situ hybridization or bright field in situ hybridization, done in case of immunohistochemistry is equivocal. 20 nuclei should be enumerated. The final results for HER2 status are reported based on the ratio between the chromosome and the gene, and formed by dividing the sum of HER2 gene signals by the sum of chromosome 17 signals for all 20 nuclei, and also based on the average of the HER2 gene signals, and formed by dividing the sum of HER2 gene signals for all 20 nuclei by 20. If the ratio between the gene and the chromosome more than or equal to, and the average of HER2 copy number per cell more than or equal 4, it's HER2 positive. But if the ratio less than 2 and the average less than 4, it's HER2 negative. While if the ratio between the chromosome and between the gene and the chromosome more than 2 but less than 4, or less than 2 and the average more than 4, additional work up is needed. This is such staining in malignant cells. The image on the left show non-amplified HER2 gene, but on the right show amplified HER2 gene in the form of clusters. So HER2 positive is reported when immunohistochemistry scored 3 or scored 2 with HER2 gene amplification by in situ hybridization. HER2 targeted therapy in HER2 positive breast cancer expanded from anti-HER2 monoclonal antibodies to tyrosine kinase inhibitors to anti-HER2 antibody drug conjugates. In summary, HER2 positive breast cancer, which is treated with HER2 targeted therapies, show dramatic improvement in the clinical outcomes. While HER2 negative breast cancer with not eligible for HER2 targeted therapy, represented by two categories, either triple negative breast cancer, which is a biologically aggressive with limited treatment options. The treatment is cytotoxic chemotherapy plus or minus immunotherapy, and chemotherapies are associated with unfavorable toxicity profiles. The other possibility, hormone receptor positive, HER2 negative, primary tumors have overall relatively favorable prognosis, but most advanced metastatic cases remain uncurable. And up to 40% of advanced metastatic breast cancer develop endocrine therapy resistance, and options are limited for lethal line of therapy. The need for improved therapeutic options in treating high risk or advanced HER2 negative breast cancer lead to HER2 low breast cancer. HER2 low breast cancer, a newly defined subset of HER2 negative breast cancer that lack protein overexpression or gene amplification, is still not well characterized clinically and pathologically. Recent clinical trials have identified HER2 low breast cancer as those with HER2 immunohistochemistry scores of 1 or 2 with in situ hybridization negative. These trials demonstrated significant clinical benefits of HER2 directing antibody drug conjugates in treating HER2 low advanced breast cancer. This is the natural history of HER2 low breast cancer clinical trials, which started from 2019 to June 2022. Based on phase 1 clinical trials, which achieved a good objective response rate of HER2 immunohistochemistry scores of 1 or 2 with in situ hybridization negative to which responds to HER2 targeting antibody drug conjugates. In 2020, first proposed the concept of HER2 low breast cancer. Then Modi et al. In June 2022 published phase 3 clinical trial, which is known by Destiny Breast 04. This trial approved the efficacy of anti-HER2 antibody drug conjugates in patients with HER2 low metastatic breast cancer with significant improvement in progression-free survival and overall survival over conventional chemotherapy. Then FDA in August 2022 approved trastuzumab deruxtecan as the first targeted therapy for the treatment of patients with unresectable or metastatic HER2 low breast cancer. The breakthrough in developing novel HER2 targeting antibody drug conjugates and identifying their clinical benefits in HER2 low breast cancer were dramatically remodeled the clinical treatment landscape and the pathologic evaluation of HER2 status. After the introduction of HER2 low in breast cancer in 2020, few studies have reported the incidence, which represents 31 to 51% of breast cancer, with slight increase in advanced breast cancer. HER2 low breast cancer is more common in hormonal receptor positive breast cancer compared to triple negative. In the current literature, the biology of HER2 low breast cancer is still limited, and whether it represents a distinct biologic and clinical group when compared to HER2 immunohistochemistry score 0 remains controversial. Few studies have revealed that most of HER2 low tumors are luminal molecular subtypes. Patients had discordant HER2 expression between pre and post neoadjuvant chemotherapy. Expression is highly unstable during disease progression. Compared to HER2 breast cancer, HER2-low breast cancer is responsive to neoadjuvant chemotherapy and have increased ERB2 central RNA expression. Moreover, have increased the prevalence of PIK3, fibroblast growth factor receptor 1, and reduced p53 mutations. Comparison of mutation spectra revealed that HER2-low breast cancer with immunohistochemistry 1 more related to HER2-0 tumors, while breast cancer with immunohistochemistry 2 plus with in situ hybridization negative more related to HER2 positive tumors. Immunohistochemistry testing as the primary method for identifying HER2-low breast cancer relies on the immunohistochemistry testing protocol and the scoring system of the ASCO-CAP guidelines in 2018. FDA recently approved the monoclonal immunohistochemistry antibody testing system used in DESTINY-Breast04, which is Ventana pathway anti-HER2 neo 4B5 rapid monoclonal antibody. What are the fundamental challenges in the pathological landscape of HER2-low breast cancer? The widely used definition of HER2-low breast cancer is only based on the inclusion criteria of clinical trials. In this trial, patients with immunohistochemistry 0 were excluded from the trial, and no evidence that HER2-low is a distinct subtype of breast cancer with different prognostic or predictive implications. Also, there are data suggesting that immunohistochemistry 0 cases also have low levels of HER2 protein expression by more sensitive testing methods. Expression is highly unstable during disease progression. About 40% of cases switching between immunohistochemistry 0 and HER2-low results when paired primary and metastatic breast cancer are compared. Trial data didn't identify a differential benefit between patients with immunohistochemistry 1 and immunohistochemistry 2 with in situ hybridization negative treated with trastuzumab deruxtecan. No developing an approved accurate testing method for HER2-low breast cancer. What are the challenges according to for HER2 immunohistochemistry testing methods which are approved by FDA to detect HER2-low breast cancer? It is a semi-quantitative test. ASCO-CAP HER2 testing guidelines 2018 in breast cancer have been focusing on separating patients with HER2-positive tumors from those with HER2-negative tumors who aren't eligible for HER2-targeted therapy. So this method may not be an ideal method for detecting tumors with low levels of HER2 protein expression. Also, distinction HER2-0 from HER2-1 cases was clinically irrelevant until the publication of the DESTINY-Breast04 results. For more than two decades, many pathologists have simply reported cases that showed HER2 staining 1 or 0 as HER2 negative. Adoption of HER2-low terminology in immunohistochemistry reporting is problematic because it would require changing the reporting scheme for immunohistochemistry 2 results, as final immunohistochemistry result category couldn't be reported as HER2-low versus HER2-positive until in situ hybridization results are back. Moreover, the pre-analytic, analytic, and post-analytic variables of immunohistochemistry testing may affect the interpretation of HER2-low cases. Finally, there is inter-observer and antibody variability in HER2 immunohistochemistry score. So, further efforts are needed to address whether immunohistochemistry testing methods would reliably identify appropriate patients for TDXD treatment or not. 23 ASCO-CAP guidelines update. The impetus for updating of ASCO-CAP guidelines in 2018 was the 2022 publication of Destiny Breast 04 clinical trial. Leads to expanding the spectrum of HER2 positivity in breast cancer from negative to HER2 ultra low to HER2 low to positive. What is HER2 ultra low? Among the immunohistochemistry score 0 category, two different types of expression are present. Either a complete lack of expression or faint incomplete in less than 10% of tumor cells, which is known as HER2 ultra low. The ongoing Destiny Breast 06 phase 3 clinical trial evaluates the efficacy of TTXT in HER2 low and HER2 ultra low metastatic breast cancer patients with disease progression on endocrine therapy. The results of this trial will provide more evidence on defining the lower limits of HER2 expression required to benefit from an antibody drug conjugate therapeutic approach and determining the clinical significance of distinguishing HER2 low from HER2 zero breast cancer by using current testing methods. What does ASCO-CAP guideline updates recommend? It recommends to continue to score HER2 immunohistochemistry using the 2018 ASCO-CAP guidelines, to pay careful attention to key analytic factors, and to use controls with a range of protein expression, including 1+ cases.
Thank you so much, Dr. Ramona, for your elegant talk. We will postpone any questions for till the end of the discussion.
Now it's my pleasure to introduce Professor Ahmed Bastawisi, Professor of Medical Oncology, NCI, Cairo University, and consultant at the Foundation. And the talk is about the EDC current clinical use and future directions.
Thank you, Professor Nirvana Magdi, for your kind introduction. My talk is titled ADC's Current Clinical Use and the Future Direction. This is the outline of my presentation. I will go for a small introduction and then what is the current ADC landscape, what is the future directions, and finally conclusions. The majority of chemotherapeutic drugs obey what is called the dose response curve. What is the dose response curve? The more you increase the dose, the more you get response within a limits. What are the limits? The limits are the toxicity of chemotherapy on the viable organs, mainly the bone marrow, the GI, and so on. And some chemotherapeutic agents does not obey the dose response curve, which is dependent on getting a better response by increasing the dose, but rather they are concerned with increasing the timing of chemotherapy. For example, the beta alkaloids, which has a dose-limiting toxicity. However, when we have tried to improve the yield of beta alkaloids, regimen like that for multiple myeloma, for example, used a continuous infusion pattern, because the continuous infusion will allow more cells to enter the specific phase of the cell cycle, which is G1S, and subsequently these cells will be prone to the action of beta alkaloids. So these are our trials to augment the value of chemotherapy. Another way to increase the response of chemotherapy was, okay, you want to increase the dose to get more response, but you have a problem of toxicity mainly on the bone marrow. Why not to take the marrow out and increase the dose to be toxic to the tumor, but subtoxic to the organs? And the marrow is taken out and then once again reinfused in what is called autologous bone marrow transplant in some hematological malignancies, and failed in some solid tumors like germ cell tumors and the rest. So this is what the oncologists, the scientists try to improve the value of chemotherapy and to increase the therapeutic window, which is the difference between the effective dose and the toxic dose. Another modality of increasing the value of chemotherapy is what is called antibody drug conjugate. What if we can take the chemotherapy and put it directly into the malignant cells? And this was the initial rationale of ADCs in order to increase our therapeutic window. And these antibody drug conjugates are formed of target antigen, which recognize the target cancer cells. Again, antibody, which guides the system of the cytotoxic drugs, and the linker, which is a bridge between the antibody and the drug. And ideally, it is cleavable at the target site. And we have many monoclonal antibodies to increase the better selectivity, for example, HER2, HER3, TROP2, and the other investigational ones. So simply the ADC will bind to its antigen on the cell surface, internalization occur, and then release of the payload. Payload is the chemotherapeutic agent attached to the antibody. And then this payload will act on the DNA, eliciting its response. And if we go back to the history, there was what is called the Trojan War, in which there was a present in the form of a Trojan horse. And when this present was accepted, the release of the concealed attackers from inside the Trojan horse. And that is why whenever you have any Trojan, any concealed attacker, it is called the Trojan horse, and that is why the ADCs are called the Trojan horse or magic bullets. And the story started from the year 20,000 up to now, and it started with what is called the Gemtuzo-Ozo, and it was tested in acute myeloid leukemia, initially failed. After approval, it was withdrawn. And this was because of some technical issues regarding the linker, the antigen, the antibody, and then was reintroduced after improvement of some technical issues and was once again FDA approved. And then the story continued until we have a long list of FDA approved ADCs for different types of malignancies, including breast, including non-small cell lung cancer. And because we are talking about breast cancer, these are the ADCs in development in breast cancer. Perhaps the father ADC in breast cancer was the introduction of TDM1 and HER2 positive breast cancer, and now HER2 and now TDM1 is already FDA approved in both metastatic disease and in the adjuvant setting if patients with HER2 positive disease not attaining a complete pathological response after initial neoadjuvant treatment. However, this session is mainly concerned with HER2-low, so I will concentrate mainly on HER2-low disease, and the definition of HER2-low was nicely presented by Professor Mona Mamdouh. I will not repeat, but as a clinician, what is the difference for me between HER2 positive and HER2 negative? Initially, we treated patients with HER2 positive disease if they are HER2 3+ by immunohistochemistry or HER2 2+ by immunohistochemistry and positive by FISH. However, if we do not have this definition, we will not have a response to anti-HER2 therapies. But the concept of HER2 is much more different because this time the antibody is just directing the cytotoxic drug or the payload to be delivered intracellularly, eliciting the response we want. And I will discuss some issues regarding this because this will challenge our understanding of ADCs. What is the percentage? Around 46% in HR positive disease and around 66% in triple negative breast cancer cases. And the first one I want to discuss is the TDXD monoclonal antibody, which is working by the same mechanism. However, it has a very unique mechanism, which is the bystander effect. After internalization, it will act on the neighboring cells, what is called bystander effect. augmenting its function. And the story initially started by Destiny Breast 1, which was a phase 2 trial in HER2 positive disease, not HER2 negative disease. And actually, because a subgroup of patients were HER2 low disease, and the subgroup analysis showed a benefit even in HER2 low disease, this led to the introduction of Destiny Breast 4, which was an open-label multi-center study in patients with HER2 low, defined as IHC 1 plus versus IHC 2 plus, but ISH is negative, unresectable and or metastatic breast cancer treated by 1 or 2 prior lines of chemotherapy in the metastatic setting, and HR positive disease is considered endocrine refractory after exhaustion of the standard endocrine-based therapies. And the patients were randomized in a 2-to-1 fashion to receive the standard TDXT dose of 5.4 milligram per kg every 3 weeks, or to receive a treatment of physician choice, like, for example, Eribulin, Capecitabine, whatsoever, whose primary endpoint is a PFS, and secondary endpoint is a PFS in all patients, not in HR positive disease, like the primary endpoint, and another secondary endpoint is overall survival in all patients and HR positive disease. And these are the patients' characteristically, which was well balanced between the two arms, and interestingly, around 2/3 of patients received the prior 3 or more systemic lines of chemotherapy, and out of these lines, around 1/3 of patients received 3 or more lines of chemotherapy, and these are the results which, fortunately, the Destiny 4 was a positive trial, and there was improvement of both progression-free survival and overall survival in the intent to treat population and in HR positive disease. Again, these are the subgroup analysis, the PFS in the HR positive disease. All the major subgroups was in favor of the TDXT in the intended to treat population, and in the subgroup analysis of HR positive disease, including patients receiving a prior CDK4/6 inhibitor-based therapy, and in a and in exploratory endpoint of PFS and OS in HR negative disease. At that time, again, was working, and there was improvement of both progression-free and overall survival. So TDXT is working in what is called HER2 low disease. But the question is, how low? And what about the degree of HER2 positivity? And this is the DAISY trial, which is a multi-center open-label phase 2 trial assessing the patients with metastatic disease post 1 or more chemotherapeutic regimen in the metastatic setting, and they were randomized to receive a cohort 1, which is HER2 overexpressed. The second one was HER2 low, as defined before, and the more interesting was the introduction of a third group, which was a HER2 non-expressing or HER2 zero. And as expected in both HER2 positive and HER2 low disease, it was working. But what was surprisingly for the Oncology Society is that it was once again working in HER2 non-detected disease. And this actually challenged our concept of ADC's mechanism of action, because it seems that it is not concerned about just the identification of antigen by monoclonal antibody and then internalization of a payload. It seems that there is another undetected methods or mechanism of action. But however, this led to the introduction of Destiny Breast 6, which was a trial in HER2 low HR positive breast cancer patients whose disease progressed after endocrine therapy in metastatic setting. What I want to say is that the question of Destiny Breast 6 is that does ADCs work in earlier line of treatments, not in patients heavily treated by chemotherapeutic drugs, and we are waiting for the results of this trial. So TDXT is already in use. It is already gained regulatory approval. What are our other targets in HER2 disease? We have trastuzumab deruxtecan, and this agent showed an overall response rate of around 28% in HER2 low HR positive disease, and a more overall response rate around 40% triple negative disease. The problem of this drug is that first, it is the first ADC to incorporate an alkylating agent as payload. And the problem was in the adverse events. I guess it will be discussed after a while. But generally, the problem was in lung toxicity and mainly keratitis. And this keratitis was a very annoying adverse event and led to discontinuation of the treatment because it led to visual disturbances, and the scientists are working to improve this adverse event. Another promising one is the lezitimab vedotin, which is also against the HER2 antibody, and it showed overall response rate of around 40%, and the payload at that time is an anti-tubulin drug. So what we have in HER2 antibody disease, we have already approved one, which is TDXT, and some promising investigational ones. Another target is the TROP2, and the TROP2 is targeted by what is called sacituzumab govitecan, which is the first in-class TROP2 directed ADC, and actually TROP2 is expressed in all subtypes of breast cancer, and it is linked to a poor prognosis. And the uniquity of sacituzumab govitecan is that it has antibody highly specific for TROP2, again a high drug to antibody ratio of around 7.6:1. And the internalization and the enzymatic cleavage is not a necessity. Again, it has a bystander effect. And the payload this time is what is called SN38. And if we remember, SN38, it was a metabolite of irinotecan, and it was linked to the toxicity of irinotecan. However, it was found that the SN38 is more potent than its parent compound, and the issue of toxicity is solved now by the ADCs. So sacituzumab govitecan was tried in 2 or more chemotherapeutic lines for advanced disease, and it was patients were randomized in 2-to-1 fashion to receive the investigational agent versus treatment of physician choice with the primary endpoint of PFS. And if we look at the results of the phase 3 ASCENT trial, it was positive. And if we look at PFS, it was dramatically improved with around a 4-fold increase in PFS. And again, the overall survival was improved. It was almost doubled with the use of this agent. Again, the overall response rate, as you can easily look, is dramatically improved with 7-fold increase with the use of sacituzumab govitecan, and the benefit was not linked to the positivity or negativity to drop. Okay, so this is in triple negative disease, and it is already approved. What about HR positive disease? This was the TROPICS-02 trial, which was including metastatic breast cancer patients, HR positive and negative, at least receiving 1 line of endocrine therapy, CDK4/6 and vaccine, 2 to 4 lines of chemotherapy for breast cancer, including those received in the neoadjuvant setting, and the patients were randomized in a 1-to-1 fashion to sacituzumab govitecan in a standard 10 milligram mg every 3 weeks, day 1 and day 8, versus treatment of physician choice. And again, PFS and OS was positive, denoting that the agent is not only working in triple negative, but also is working in HR positive disease. And if we look at the HER2 status, it was working in post HER2 low, HER2 immunohistochemistry 0, the value was much more less, and in the intended treat population, but it was once again challenging our concept of the mechanism of action of ADCs. So it is already approved. What about the investigational agents? We have the botumab deruxtecan, which is unique in having a payload, TOP1 inhibitor, high potency of the payload, optimized drug-to-antibody ratio amongst many other different mechanisms, and it was tested in a very important clinical trial, which is Propion pan-tumor in different solid tumors, the phase 1 clinical trial. If we look at the cohort of triple-negative breast cancer patients, the overall response rate was 34%, and in patients not receiving a TOP1 inhibitor previously, 52%. Again, it was working in HR positive disease, and we are eager to follow up the confirmatory trials of these agents. What about our novel targets? A long list of payloads and antibodies are there with a very promising one, which is the HER3 overexpressed in metastatic breast cancer and associated with worse survival. And this agent was tested in this clinical trial. And once again, it was working across all breast cancer subtypes. However, we are waiting for a more mature clinical trial. This is the standard. What about the future directions? The mechanism of action initially was based on the tumorigenesis. Okay, we have HER2 augmented, HER2 overexpressed, binding of a receptor to HER2 will lead to downstream signaling from the cell membrane to the nucleus, altered DNA, altered transcribed RNA and the protein product, which will elicit tumorigenesis. This is in HER2 positive disease. But why the ADCs is not only working in HER2 low and in HER2 ultra low, but also working in HER2 zero disease? This puts a question mark about our understanding of the mechanisms of action of ADC and subsequently the mechanisms of resistance for ADCs. Again, what about sequencing of ADCs? ADCs trial showing a benefit of TDXT after TDM1. However, what about if we have the same payload? Will it still be working? Once again, what about combining this agent with different targeted agents and different immunotherapeutic agents? And these are the clinical trials in different malignancies with EDPases, combinations with different payloads and with different targeted and immunotherapeutic drugs. And if we look at this landmark trial, it was for combining ADC with either durvalumab or pembrolizumab, and it was working, and we are waiting for confirmatory clinical trial. Again, what about the combination of sacituzumab, TNBC, plus or minus the standard treatment, which is pembrolizumab in the neoadjuvant setting? Again, this is the Destiny Breast 7, which is including different combinations with chemotherapy, with immunotherapy, with targeted agents, with a promising results, and a long list of trials are there. The last one I want to elicit is the movement of ADCs from further line of treatments to first line metastatic triple negative and HR positive disease. And what was more interesting is the introduction of ADCs in early breast cancer in patients not attaining complete pathological remission after introduction of the standard neoadjuvant. For example, in triple negative, the standard of pembrolizumab, chemotherapy, and so on. So, in conclusion, a new player in the armamentarium of treatment of metastatic breast cancer. We have changes that, for example, in HR positive disease. هو المايك موجود مش مشكله بقى المايك. In HR positive disease, we have already two agents in further line of treatments, post progression on 2 or 3 lines of chemotherapy, and in triple negative disease we have sacituzumab govitecan already approved, and a long list of drugs. What are our future directions? Future direction is about what about the real mechanism of action, the real mechanism of resistance? What about different combinations? Chemotherapy, immunotherapeutic and targeted agents, and what about better understanding and better movement of ADCs from later lines to further lines of metastatic disease, and the more importantly, for early breast cancer. And with this, I thank you for your attention.
Thank you so much, Dr. Ahmed, for the very, very elegant presentation, very informative. We will postpone the questions till the end of the session. Now it's my real pleasure to introduce Dr. Abdelhamid Fouad, medical oncology consultant in Bahia Hospital. And the topic will be the toxicities of the ADC and their management.
Good afternoon, ladies and gentlemen. Thank you, Professor Ahmed. You already helped me a lot. He paved the way for this hard task. I will not implement the adverse treatment, adverse event manage that. This is how the story began. As we talked, chemotherapy has potent toxicity to cells, but it had aggressive side effects. On the other hand, monoclonal antibodies are highly specific, have some anti-tumor activities, but they lack sufficient cytotoxicity. The idea of ADCs is to combine the cytotoxic drugs with the monoclonal antibodies to create highly specific molecule with potent cytotoxicity. And this is the structure, as Professor Ahmed mentioned. We have a high therapeutic index molecule, better than the chemotherapy alone and the monoclonal antibody alone. This is the mechanism of action: binding, internalization, transportation by lysosome, then degradation, releasing the active payloads, leading to cytotoxicity. And they have also the bystander effect, the third generation of the ADCs. They can be released from the ADCs after binding and before internalization in the tumor microenvironment, or by diffusion from the malignant cell to the other tumor microenvironment. ADCs have been investigated in breast cancer, as we saw with Professor Ahmed, mainly targeting HER2 and TROP2. And nowadays we have 3 approved ADCs in the breast cancer field: the TDM1, the TDXD, and the SG. They are approved in several indications in breast cancer, including triple negative, HER2 positive, and HER2 negative. Also, and we have in the pipeline 3 molecules waiting approval in the recent future. And as we can see, SADCs are incorporated in the treatment algorithm of HER2 positive, hormone positive, HER2 negative, and in triple negative breast cancers. The mechanism of toxicity in ADCs is mainly related to the release of the payload and the stability of the linker and internalization. They have an anti-tumor effect, and that means when the payload is released in the tumor microenvironment, in the absence of a target, they do some cytotoxicity to the neighboring anti-tumor cells. But the off-tumor effect, which is the cause of the side effects, it may be due to release of the payloads in normal cells, either in the presence of the target cells, what's called off-tumor on-target, or in the absence of targets, what's called off-tumor off-target. And the mechanism is either the ADCs enter the normal cells by non-specific endocytosis, or by binding to target on normal cells, or binding to Fc receptor for normal cells. Here the payloads are enter the normal cells and cause cytotoxicity. Also, the payloads can enter by passive diffusion after they are deconjugated from the antibodies before internalization, or after they have been released from apoptotic tumor cells. The structure of the antibody can affect the mechanism of toxicity. Either the linker is cleavable or non-cleavable, the payload, mode of action, the drug to antibody ratio, the monoclonal antibody itself can affect the side effects of the ADC. Also, there is factors related to the patients like age, affinity, comorbidities, and body composition. This table shows the approved ADCs and the common adverse events in most of the clinical trials, and also this one shows the dose-limiting toxicities based on the payload classes. A large meta-analysis published the last year, including 169 trials, the overall grade toxicity related to the ADCs was too high. It was about 91%, and the grade 3 or more adverse event that and the adverse event lead to treatment discontinuation was about 46 and 13.2 respectively. Also, in this meta-analysis, we found that the adverse event that can lead to death was 1.3. So, ADCs is not a magic bullet. It needs some understanding of the mechanism of action and the mechanism of toxicity, because still they have toxicity. In breast cancer, and we will focus on this ADCs in breast cancer, this is the most common reported treatment-related adverse event in breast cancer. TDM1, TDXT, and SG, and the commonly reported adverse events. We will go deep in some adverse events like hematological toxicity. Any type can occur. Neutropenia is most commonly seen with SG. It's grade 3 or more reported in 13% in the clinical trials for SG. TDXT is lower and TDM1 is much more low. How to manage neutropenia in patients with ADCs? UCSF prophylaxis can be used in high-risk patients or in moderate risk, but he has other risk factors. Dose reduction is required if the patient has recurrent neutropenia or patient cannot withstand side effects of GCSF. Prophylactic antibiotics should be given to patients if patient is ferric count is than 100 or for deep neutropenia lasting for more than 1 week. Ferric antibiotics should be started immediately if the patient has neutropenia with fever more than 38. Anemia is can be reported in trials for the 3 approved ADCs, and it's mostly grade 1 and 2. But in case of grade 3 to 4 anemia, the treatment should be halted until recovered to less than grade 2, then resumed with a lower dose level. Platelet transfusion should be given in case of grade 4 anemia or patient with grade 3 with symptoms, or according to the institutional guidelines. In case of grade 2 anemia, we have to evaluate the serum iron level, and iron supplementation should be given. The erythrocyte stimulating agents till now have not been investigated in patients receiving ADCs. Thrombocytopenia is frequently seen in trials for TDM1, and TDXT and SG is very low incidence to find thrombocytopenia. Patient having thrombocytopenia, the treatment should be halted until recovery to less than grade 1, then can be resumed at the same dose. Dose reduction is required for naive patients if treatment is delayed for more than 2 weeks due to grade 2 to 3 thrombocytopenia. In case of grade 4 thrombocytopenia, when the drug is restarted, also need dose reduction. Treatment discontinuation should be done if the patient have grade 3 or 4 and not resolved to less than grade 1 within 42 days. Platelet transfusion should be done in patients having active bleeding or patients with platelet count less than 10,000 or 20,000, but if he has fever. The platelet receptor antagonist can be used, although not having approval, lacking FDA approval, but can be used for patients cannot be supported by platelet transfusion. This is the treatment algorithm for monitoring and management for hematological toxicity. Toxicity is expressed in the cardiac cells and has an important role in management cell growth, homeostasis, and oxidative stress cardiac cells. Also, it plays a critical role in the development of the fetal heart. These side effects are frequently seen in patients treated with anti-HER2, can be reversible or irreversible. Patient may having asymptomatic cardiac toxicity or having one or more of these 2 symptoms. The trials for the TDM1 show from 0.8 to 1.5% cardiac toxicity, and also TDXT patient observed reported some cardiac toxicity. SG is not reported to do cardiac toxicity. The most important thing in managing cardiac toxicity in patients receiving ADCs is baseline screening and monitoring during the treatment. The patient should be evaluated if he received previous cardiotoxic drugs, cardiovascular history, physical examination, lab tests like cardiac enzymes, ECG, or thoracic echo. The European School of Cardiology recommended that patients treated with ADCs having symptomatic mild to moderate can continue with treatment, but with giving cardioprotective drugs like ACE inhibitors or ARBs or beta blockers. Symptomatic mild to moderate should, treatment interruption should be done, and asymptomatic severe cardiac toxicity also treatment interruption should be done. This also is a treatment algorithm for patients receiving TDM1 either in the early breast or metastatic setting, and on the right, the treatment algorithm for monitoring and managing cardiac toxicity related to TDX. GI toxicity are frequently reported in patients with ADCs, most related to payloads, including nausea and vomiting. Nausea and vomiting impair quality of life and can lead to metabolic imbalance and nutrition depletion. Acute delayed anticipatory breakthrough nausea and vomiting can happen. TDX3 is highly emetogenic, and SCG with high-grade nausea and vomiting. In moderate emetogenic drugs, we can give day 1 DEXA plus 5-HT3 antagonist and continue with 5-HT3 in day 2 and 3. In highly emetogenic, we should give 3 drugs, DEXA plus HT3 antagonist and day 1 antagonist, and continue with NK1 antagonist in day 2 and 3. Breakthrough fever should be managed by metoclopramide. Refractory nausea and vomiting, olanzapine is very helpful. Anticipatory vomiting, very important to treat acute and delayed vomiting. Anxiolytic drugs like lorazepam and relaxing measure can help to control anticipatory vomiting. Diarrhea may be related to the release of payload before to the normal tissue. SG causes diarrhea in most of the cases with high grade 3 reaching 10%. TDM1 and TDX3 have low incidence to develop diarrhea. Specifically, diarrhea is high in SG because the active metabolite SN38 and the diarrhea is related mainly to topoisomerase 1 inhibitor that is included in the DXT and SN38. But in case of SN38, the patient having higher incidence of diarrhea because SN38 have particular and unique metabolism. It is deactivated in the liver, but unfortunately the gut microbiota can reactivate it in the gut, leading to high grade of diarrhea, which is not the case with DXT, which is deactivated in the liver and not reactivated in the gut again. Managing diarrhea according to the onset. In case of early onset, atropine administration is very important. In case of late onset, loperamide should be started, and in case of failure of loperamide, short-acting octreotide is very helpful. Diarrhea with fever, antibiotics should be given if fever lasts for more than 24 hours or is accompanied with neutropenia. And non-pharmacological therapies like taking soft diet, plenty of fluids, and avoid lactose-containing food. Oral mucositis, I will jump. Oral mucositis, liver toxicity is very common in patients receiving TDM1. 30% of patients, no guidelines for managing liver toxicity. But in case of grade 3 elevation of ALT or AST or bilirubin, the treatment should be interrupted and reduced to grade less than grade 2 after recovery to normal. Interstitial lung disease is very important side effect in case of ADC. Maybe idiopathic or triggered by other factors like viral radiation exposure. This is the risk factors. Maybe asymptomatic or having one or more symptoms. The patient may have abnormal blood gases or deterioration in respiratory function test. Radiologically, we can see different pattern of interstitial lung disease. It may be unilateral or bilateral. The most aggressive is the diffuse alveolar damage in the upper picture. Organizing pneumonia can be like organizing pneumonia. Hypersensitivity pneumonitis in the third picture, or non-specific interstitial pneumonitis. Can lead to several complications ending with cor pulmonale and death. It is the diagnosis of exclusion, and this is very important. The patient should be evaluated for symptoms, careful examination, do physical examination, imaging to rule out other causes of lung symptoms. TDXT has higher incidence to severe lung disease. We have to incorporate synergy, incorporate multidisciplinary, so the whole drug if the patient is suspected to have interstitial lung disease, and steroid has a very important role in managing. This is an example of patient having lung cancer with HER2 positive treated with TDXD. After 2 weeks, he developed interstitial lung disease, and when receiving 4 weeks of IV methylprednisolone, he had marvelous response. Peripheral neuropathy is reported. The main important thing to control pain with several factors. Strong evidence that physical exercise, cryotherapy may help. Ocular toxicity also can be seen. TDM1 especially have particular ocular side effect because it is excreted in the tears, leading to lacrimal duct stenosis that requires surgeries at some time. It's important for the physician to be aware for this ocular toxicity, to monitor and manage in this good time. Alopecia can also occur, rash, fetal toxicity. It's not, it is no evidence that it is safe to give in pregnant women. ADCs have fetal toxicity. A mother study is a prospective observational study, including patient pregnant or up to 7 months after conception receiving anti-HER2 treatment. The result of this trial will help to assess the safety of trastuzumab in pregnant females. Potential strategies have been tried to minimize side effects by understanding the mechanism of toxicity. These strategies include dose optimization strategies, drug engineering for the antibody or the conjugation, pharmacogenomics for better selection of the patient and the dosing. To conclude, the rise of ADCs made a great breakthrough in cancer treatment, overcoming the challenge, the mechanism of underlying adverse effects, the pharmacokinetics, and the drug resistance need comprehensive comprehension. Awareness and proper education are key to guide clinicians to timely and identify and proper manage adverse event, to preserve the patient safety, and to avoid premature discontinuation or unneeded dose reductions. And thank you for your
Dr. Abdelhamid. Now, the next speaker will be Dr. Marihan Foda. She will talk about transfusion medicine and breast cancer, the good, the bad, and the ugly.
Thank you, Chef Dr. Amali, for this introduction. I'll be talking about breast cancer and transfusion medicine, the good, the bad, and the ugly. Breast cancer is the most common female cancer globally. Approximately 20% of patients eventually developing metastatic disease. Anemia is present in more than half of cancer patients, which is an independent prognostic factor for short and long-term adverse outcomes. Because this anemia increases in the advanced period of cancer, and perioperatively, patients with solid tumor who undergo surgery. Blood component therapy is an indispensable treatment in cancer. Over 85 million units of packed RBCs are transfused globally, and up to 15% of the transfusion resources are used by the oncology services in the USA. Now let's talk about transfusion medicine in a good way. So the causes of anemia in cancer patients include if there is any intratumoral bleeding, intrahumeral bleeding, there's generalized bleeding, or it could be due to chronic inflammation, nutritional deficiencies, hemolysis, DIC. It's particularly common in hematological malignancies, and anemia is also very common due to chemotherapy and radiation therapy. Also, blood loss perioperatively is a very important cause of anemia. Causes of thrombocytopenia and coagulopathy in cancer patients include chemotherapy, radiotherapy, hematological malignancy, anti-IC. So we can say that indications of the blood transfusion in oncology can be broadly divided into 4 scenarios. A perioperative oncology patient with a curative intent, anemia in a patient with pathological or solid organ malignancies who requires blood transfusion for cure, if there is any acute massive hemorrhage or an emergency, and chronic severe anemia in a patient with a palliative intent of care. These are, in short, the guidelines of blood product transfusions. These guidelines are basically by the Association of Advancement of Blood and Biotherapies. It released guidelines in 2016 regarding the RBCs, in which transfusion is indicated in hospitalized stable anemia of about 7 grams per deciliter. In patients undergoing major surgery, it's indicated when the hemoglobin is 8 grams per deciliter. And if the patient has history of cardiovascular disease, we give blood transfusion at if it is less than 8 grams per deciliter. As regards platelets, the same association released guidelines in 2015 in addition to the ASCO guidelines, which have different indications for platelets according to the problem the patient has. For example, the cutoff for platelets in patients with hematological malignancies or undergoing cell transplant or solid tumors less than 10,000 per microliter. As regards patients undergoing lumbar puncture or major surgeries, it could rise to about less than 50,000 per microliter. And for bone marrow aspirations and biopsies and insertions of CVPs, we might have to give platelet transfusion at less than, if the patient has a platelet count of less than 20,000 per microliter. As regards the plasma, it is usually given or administered to patients who are suffering from coagulation deficiencies or in case of surgeries when we have to start a massive transfusion protocol. As regards of perioperative requirements in breast cancer, in cancer in general, the perioperative packed RBCs transfusion is generally high, and it differs from cancer to cancer. For example, it's about 9.4 to 55.5 in lung cancers. It's about 40 to up 83% in breast cancer, and 7 to 40% for prostate cancer, and 60 to 90% for colon cancer. There are certain literatures that even go on as much as to say that the requirements for breast cancer can reach up to maybe less than 2.1%, perhaps 3.4%. So there's a wide range between the requirements of perioperative requirements of breast cancer patients for blood transfusion. Given these numbers, they reflect the lack of consensus on triggers of blood packed RBCs for transfusion with cancer. So many people cannot agree what are the exact triggers of blood transfusion. And it was also noticed that blood transfusion was linked to increased overall survival in breast cancer patients. We have the available evidence that regarding the perioperative blood and blood transfusion impact in cancer. For example, there is no association regarding cervix cancer or metastatic metastasis in the lung bones or spinal metastasis. However, there is conflicting evidence regarding hepatobiliary carcinomas, bladder cancer, and ovary cancer, and it was shown that blood transfusion can have a negative impact on gastric cancer, esophageal cancer, and as you can see, breast cancer. So, talking about the need for blood transfusion in breast cancer, especially in patients receiving chemotherapy. In a study by Ramzi et al. In 2023 on 140 newly diagnosed breast cancer, they showed that the pre-chemotherapy level in breast cancer patients was in about 60% almost normal, and more than 30% they had mild anemia. And around 30% of the patients required red blood cell transfusion, with more than half of the patients requiring 1 unit and about 40% requiring 2 units. And blood transfusion has been shown to show statistically significant improvement in fatigue and breathlessness among palliative breast cancer patients after blood transfusion. They also have been provided a rapid response to anemia related to symptoms, improving the patient's overall performance and quality of life. And using a restrictive transfusion strategy, which is giving a blood transfusion for a patient who is less than 7 grams per cent, rather than above that, was associated with reducing blood utilization without increasing the perioperative morbidity and cancer-related mortality. They also showed that a decline in hemoglobin was expected among blood cancer patients undergoing chemotherapy, regardless of their stage of cancer, age of diagnosis, pre-treatment hemoglobin, or types of chemotherapy or concomitant radiotherapy and hormonal therapy. So we have to expect that any patient with breast cancer will have an anemia at any stage or at any time during this. Since the cancer patients are at risk of developing cancer-induced anemia, we have to identify the mild anemia as early as possible and initiate oral iron supplement therapy to replenish the iron stores. We can use transfusion alternatives, and they have proven to improve the hematopoietic response to the chemotherapy while minimizing the risk of allogeneic blood transfusion. Parenteral iron was used in combination with erythropoiesis-degrading agents, and when compared to ESAs alone, they have demonstrated a significant hematological response. However, ESAs, they are controversial in that they may cause thrombosis, so they are thromboembolism and tumor progression, so they are only recommended for palliative patients with hemoglobin less than 10 grams per deciliter. Now let's talk about that side of blood transfusion. Of course, we're talking here about adverse reactions of blood transfusion. Since they are the most frequent therapeutic procedures, however, they have some substantial risks, and approximately 1% of transfusions result in a potentially life-threatening adverse reaction. Of course, transfusion reactions vary in severity and etiology, and they include allergic anaphylactic reactions, febrile non-hemolytic reactions, hemolytic reactions, septic reactions, nucleic acid overload, and inflammatory lung injury. This is a table that shows the different signs and symptoms of different adverse reactions. For example, fever is more common in febrile non-hemolytic transfusion reaction, which was shown to be due to release of cytokines from the donor blood, hemolytic transfusion reaction, which is due to incompatible blood, septic transfusion reaction, which was implicated more with platelet transfusions, and transfusion-related acute lung injury was implicated with plasma components due to HLA antibodies. And maybe this has caused that blood banks nowadays, they will discard plasma from donors, or female donors who have been previously pregnant, so as to prevent TRALI from occurring to the recipient. Also, transfusion-associated graft versus host disease is common in more in hematological malignancies. Another symptoms such as rash and pruritus occurs in transfusion-related allergic reaction, where the recipient has an allergic reaction to proteins in the blood component, or rather in the plasma component. Also, it may occur with transfusion-associated graft versus host disease. Dyspnea also is another symptom which occurs with anaphylactic reaction, especially in patients who have IgA deficiency and receive plasma components that contain IgA. And again, TRALI, transfusion-associated circulatory overload, especially in old patients who have cardiac insufficiencies or inefficiency, and transfusion-associated dyspnea and air embolism. And finally, hypertension, which occurs in hemolytic transfusion reaction, sepsis, acute lung injury, allergic reactions, and hypertensive transfusion. Of course, the most effective strategy in preventing any transfusion reaction is reducing the number of transfusions administered. And each blood transfusion should be clinically indicated. We should not depend on the hemoglobin as the only trigger to provide blood back or received to the patient. So, safe administration of blood transfusion requires effective communication and collaboration between the transfusion services, the healthcare providers, and the nursing staff. And also, we should try a restrictive approach to perioperative blood transfusion, especially in microvascular breast reconstruction. Thus, we can prevent. They have been shown to help and avoid increasing post-operative. Now we come to the IV side. Giving blood transfusion deliberately and without clinical cause can trigger some negative impacts in the patients receiving the blood. And since in some cases there are absence of evidence-based guidelines for transfusion, the transfusion practices will vary from different oncology centers. And the latest AABP guidelines for transfusion set the transfusion threshold between 6 and 9, depending on the clinical judgment, unless this led to arbitrary transfusion practices rather than physiological necessity-based transfusion. There is also a debate regarding the age of the red blood cells, the effect of the age of the red blood cells on the patient outcome, and there are still clinical trials addressing this. The TRIM, or the transfusion-related immune modulation, is a complication associated with administration of blood component therapy. It was noted that there is a decrease in immune surveillance as a consequence of transfusion of packed RBCs, which there are residual viable leukocytes, apoptotic cells, and various biological responses that have been linked to cancer recurrence and progression. In terms of platelets and microparticles and fresh frozen plasma, they were shown to likely stimulate tumor growth and spread. There's also increasing evidence that activated platelets may promote metastasis. And we're talking about the platelets that are transfused to the patients. So they promote metastasis and proliferation of cancer cells, while cancer cells, on the other hand, also induce more platelet activation. So we have a vicious circle of interaction between the activated platelets and the cancer cells, and it is harmful for the prognosis of cancer patients, and it has been shown to cause an increased tumor recurrence and decreased 5-year survival rate. This is the mechanism of cancer progression from packed RBCs transfusion. As we can see, we have the TRIM arm, in which the RBC storage lesions, the residual leukocytes, the cytokines reduced from the white BCs, and the cell-derived microparticles will lead to decrease the interleukin-2 and T helper cells, increase the natural killer cells, increase the interleukin-10 and the Tregs, and thus it will cause immunosuppression. And on the other arm, which is the non-TRIM arm, which is due to the RBC storage lesions and residual cytokines, which will increase inflammatory cytokines and free hemoglobin, and all this, both arms will lead to cancer growth and dissemination. Some studies regarding blood transfusion rate of tumor recurrence in gynecological cancers have shown a higher risk of distant metastasis and increased overall survival in cervical cancer treated with radiotherapy and receiving blood transfusion. In another study on 130 patients, it was shown that there was a tumor survival with primary radiation therapy for cervical cancer who received blood transfusion. Also, there was an association and a poor outcome, and the perioperative blood transfusion was documented in advanced ovarian carcinoma with recurrence and mortality, increased mortality adjusting for age and tumor grade. In surgical context, there was decreased 5-year survival rate was when we compared between the autologous blood transfusion and allogenous and untransfused patients. There was it ranged between 90.9% in the non-transfused patients, allogeneic autologous blood transfusion, and decreased in 88% in untransfused patients and 81% in patients receiving allogeneic perioperative lung transfusion. Paradoxically, in the context of breast cancer, who receive labs for breast reconstruction, the perioperative blood transfusion does not seem to be an independent risk for metastasis or cancer recurrence. This concludes that the association between perioperative blood transfusion and the negative outcome in patients with cancer is not consistent across all malignancies. It seems to be of importance in the GIT, head and neck, and urological malignancies, and less pronounced in breast and gynecological and prostatic tumors. Also, it causes confusion to us because it's not dependent on just one factor. There's an interplay between the donation association factors, recipient characteristics, inflammation, infection, coagulation. We're even talking about the plasticides that are in the blood banks that contain the blood or the plasma. All these are different factors that may cause recurrence of or may play a role in the recurrence of the cancer. So, in conclusion, we have to cancer patients are often require blood transfusion therapy during the course of their illness. The decision for transfusion of blood products should be based on correct physiological knowledge and principles and assessments of the patient risk factors. We should implement safe transfusion practices to ensure good outcomes in these patients. And since blood is a very valuable healthcare resource, and clinicians should have the knowledge of the potential risk and complications of blood intervention, as well as the ability to properly identify the patients most likely to benefit from such interventions. Thank you.
Professor. Thank you, Professor Mirhan Fouda, for your elegant talk. Now we are going to present Professor Dr. Amani Hilal. It's an honor for me to present her. The talk about CD4, CD6 inhibitors in advanced breast cancer.
Good afternoon, everyone. Thank you for being patient with us for this long session. And thank you to the Lincoln's team for giving me the opportunity to be with you. And this presentation, thank you for the introduction. Now the presentation is about CDK4/6 inhibitors and advanced hormone receptor positive, HER2-negative breast cancer. This is the treatment outline. This is the outline of the presentation. Treatment of advanced hormone receptor positive, HER2-negative advanced breast cancer, and the role of CDK4/6 inhibitors in this subset of patients, and the outcome from the CDK4/6 as an overall survival, efficacy in young patients, efficacy in endocrine resistant cases, and what is the role of the CDK4/6 inhibitors after progression on the treatment with the CDK4/6 inhibitors. Some facts we should all agree on. The hormone receptor positive breast cancer patients represent the most common subtype of the breast cancer, about 60 to 75%. And all guidelines, the backbone for the treatment of advanced hormone receptor positive HER2-negative breast cancer is the endocrine treatment, except in patients for visceral crisis. However, this subset of patients now can be treated with some sort of endocrine treatment, and up to 50% of hormone receptor positive patients with metastatic disease develop mechanism of therapeutic resistance when they are treated with the single agent hormonal treatment we all know about. So this was the research point to start trying to overcome the resistance developed to the hormonal treatments by combining targeted and anti-estrogen therapies to overcome such a resistance to hormone receptor positive disease. And one of these drugs that have been invented to be combined with hormonal treatment is the CDK4/6 inhibitors, which causes the arrest of the cell cycle, preventing the cell from passing from the G1 to S phase and causing apoptosis. It's very short. There are a breakthrough in the hormone receptor positive treatment of the breast cancer. Starting from the tamoxifen in 1980s, then passed to the gestrol acetate, the aromatase inhibitors in 2002. Then 10 years later, start to have some target therapy to overcome the endocrine resistance, starting with the everolimus exemestane, and then 3 years later, start the CDK4/6 inhibitors, and the passing till now the IQ3 mutant drugs and the antibody drug conjugate that has been beautifully introduced by Professor Ahmed Bastawisi and Dr. Ami Hakim. These are the phase 3 CDK4/6 inhibitor clinical trials that we all know. There are 3 CDK4/6 inhibitors approved for the treatment of breast cancer, the valprocycline, the abemaciclib, and the ribociclib. And there are 3 groups of trials testing these 3 drugs, either as a first line or a subsequent line in the postmenopausal patients and some or all Melisa 7 before the premenopausal. However, the premenopausal was involved in some of these trials, and the combination with aromatase inhibitor or with fulvestrant. Overall, the survival is an ultimate goal. The improvement in the overall survival were not observed among patients with metastatic breast cancer in 2013. This is the problem. We don't have an overall survival advantage, and this led to the use of the progression-free survival and overall response rate as the endpoint for the trials in the treatment of metastatic breast cancer. However, the key goal in the treatment of the metastatic breast cancer is to prolong survival with an emphasis on restricting treatment-related toxicity as much as possible. Of course, the need also to time to disease progression is increasingly used as primary endpoint. However, the overall the survival is the key or the goal endpoint that we should all use in the clinical trials for the treatment of metastatic breast cancer, and this was stated by the FDA. Overall survival is considered the most reliable cancer endpoint, and when studies can be conducted to adequately assess survival, is usually the preferred endpoint. Now, these are the CDK4/6 inhibitors in the first-line trials, and all showed a significant improvement in the progression-free survival by about 10 months for all of the trials, whether the abemaciclib or the valprocyclib or the ribociclib. However, go to the overall the survival. For there are 3. I will start with the first-line CDK4/6 inhibitor trials, or the PALOMA-2, Melisa-2, and NARC. The 3 trials included the postmenopausal patients who developed metastasis more than 12 months after ending the adjuvant treatment, or those presented with de novo breast cancer metastasis, or in other words, for the endocrine-sensitive disease. For the PALOMA-2 trial, there is no evidence of the improvement in the overall survival, and for the NARC-3, there is numerical improvement in the overall survival. However, it is not mentioned. We pre-specified the boundary for considering it as a significant, while for the Melisa-2, there is significant improvement in the overall survival. For the 3 trials of the first line, the CDK4/6 inhibitor was combined with the aromatase, non-steroidal aromatase inhibitors. For the MONALEESA-2, the median overall survival for patients who received the ribociclib was the 63.9 months, more than 5 years, compared to 51 months improvement of about 1 year than using the single agent hormonal treatment. And this improvement in the overall survival, the difference between using the ribociclib in the combination with the endocrine treatment versus single agent, is increasing over time, starting by 5.7% in the first 4 years, and now the difference is 12.2% at 6 years follow-up, with the improvement of the overall survival. Passing to the post-AI trials, whether using after the aromatase inhibitors, the PALOMA-3 and NARC-2, MONALEESA-3 and NARC-1. NARC-1 is single agent abemaciclib. For the PALOMA-3, NARC-2 and MONALEESA-3, the combination of the CDK4/6 inhibitors is with fulvestrant, not aromatase inhibitors. And again, the 3 drugs give significant improvement in the progression-free survival, although the benefit is slightly less than that of the first line, but still there is significant improvement in the progression-free survival. This is the PALOMA-3, included the patients after the progression on the previous line of the endocrine treatment or previous line of chemotherapy for metastatic disease, and the addition of the valprocyclib with the fulvestrant, though improved the progression-free survival, didn't aid to the overall survival. For the MONARCH 2, combination of the abemaciclib and the fulvestrant improved the median overall survival to about the 9 months, 46.7 months versus 37.3, and this was a significant improvement in the overall survival. For the MONALEESA 3, and the MONALEESA 3 has two subset of the patient population, whether used as first line for the patient either de novo or those relapsing after 12 months completing adjuvant treatment, and another type of population, those who progressed on the first line endocrine treatment, or they progressed to less than 12 months of the adjuvant treatment. For the whole population, there is a significant improvement in the overall survival, with a median overall survival of about the 54 months versus the 42 months for those who didn't receive the ribociclib treatment. And this overall survival benefit was maintained with the first line and second line, although it was pronounced in the first line, but still there is significant improvement in the overall survival with the use of ribociclib in the second line. So when we want to summarize all the trials using the valco and abemaciclib and ribociclib as regarding the significant overall survival benefit, there is an improvement of the overall survival for the MONALEESA 2 for ribociclib, and the abemaciclib, although there is a numerical difference but not statistically significant, and for the MONALEESA 7, MONALEESA 3, and the MONARCH 2. To summarize, giving the CDK4/6 inhibitors with the hormonal treatment resulted in significant improvement in the overall survival with the ribociclib in all the trials, whether used as the first line or second line. While in the abemaciclib, the addition of the mainly fulvestrant with the abemaciclib resulted in significant improvement in the overall survival, but not with the aromatase inhibitor as first line, and the valprocyclib, unfortunately, no improvement in the overall survival had been observed with the combination with either aromatase inhibitor or with the fulvestrant. When trying to define which group of patients would benefit more from the addition of the CDK4/6 inhibitors to the hormonal treatment, in the MONALEESA trials, all patients with the visceral metastasis improved with the addition of the ribociclib, and the same with the abemaciclib, especially those with single liver metastasis, and there is no improvement in the PALOMA trials except for the non-visceral disease. For this abemaciclib, the improvement was pronounced in the visceral but not in the bone-only disease. However, the ribociclib demonstrated a clinically meaningful survival in the benefit in the patients with the visceral metastasis. Now going to a very important subgroup of patients, the young or the premenopausal patients. Premenopausal breast cancer is the most frequently diagnosed cancer among women worldwide. We all know this fact. It is the most common cancer diagnosed in the females. And the premenopausal, those younger than 50 years of age, are a higher proportion of patients in Asia, Pacific, and Middle Eastern regions. And about 2/3 of the premenopausal women with breast cancer have the hormone receptor positive HER2 negative disease as the most common subtype of breast cancer. And compared with high-income countries, patients in low and middle-income countries are more frequently diagnosed at an advanced stage, and the premenopausal patients with the static breast cancer tend to have more aggressive and poorer prognosis than those with the disease in older patients. The first trial that has been only confined to the premenopausal patients is the MONALEESA 7. This is a phase 3 randomized double-blind placebo-controlled trial involving the pre- and the perimenopausal women with hormone receptor positive HER2 negative, no prior endocrine therapy for advanced disease. However, the one line of chemotherapy is allowed before introducing to the trial, and the patients with the no previous line or the first line treatment is also allowed. Patients were randomized to receive either ribociclib plus the tamoxifen or non-steroidal aromatase inhibitors versus the placebo blastamoxifene and non-steroidal aromatase inhibitors. And as I've shown you before, the progression-free survival is significantly improved. For the overall survival, the addition of the ribociclib for the whole group of the treatment population, the ribociclib plus the endocrine treatment result in overall survival of the 58.7 compared to 48 months for those who didn't receive the ribociclib in the treatment. So there is an improvement of about more than 10 months. And this improvement is more pronounced in younger patients. Patients younger than 40 years showed the improvement of about more than 11 months in the median overall survival. Prolonged overall survival with relative reduction risk of death of about 35% for those younger than 40 years. However, there is still improvement in the patients older than 40 years about reduction in the risk by the 19%. Now going to the other trial, right choice study, and we were sharing involved in this trial, and the principal investigator is Dr. Ahmed Bastawisi. This trial did something which is not usual. She included young patients with a very aggressive disease, and there to study the population of CDK4/6 inhibitors plus the hormonal treatment for treatment of such patients, while in our practice, when we are meeting premenopausal patients with a very aggressive disease and rapidly progressive impending visceral crisis, we are not even thinking about the hormonal treatment. We are only thinking about chemotherapy, and not only chemotherapy, combination chemotherapy. So look to the design of this study. Hormone receptor positive HER2 negative advanced breast cancer, very old premenopausal women, age 18 to 59, no prior endocrine treatment or chemotherapy for the advanced disease, performance status less than or equal to, and total bilirubin is less than or equal 1.5, with symptomatic visceral metastasis, rapid progression of the disease of impending visceral compromise, and markedly symptomatic non-visceral disease. So very aggressive disease, randomized in 1:1 ratio to ribociclib or plus non-steroidal aromatase inhibitor, of course with LHRH, versus the investigator choice of combination chemotherapy, docetaxel plus capecitabine, paclitaxel plus gemcitabine, or capecitabine plus vinorelbine, very effective combination chemotherapy versus the hormonal treatment, and the endpoints, the progression-free survival. This is the primary and secondary clinical benefit rate, overall response rate, overall survival, time to treatment failure, safety, and tolerability. And these are the definitions of the visceral crisis according to the ESO and ESMO guidelines, where there is the severe organ dysfunction as assessed by signs and symptoms, laboratory studies, and rapid progression of disease. Visceral crisis is not the mere metastasis of visceral metastasis, but implies important visceral compromise leading to clinical indication from a more rapidly efficient therapy, particularly since another treatment option at progression is probably not possible. And this is the definition for the indications for patients involved in the right choice study. And the first line ribociclib plus endocrine treatment achieved a statistically significant progression-free survival benefit of about 1 year over the combination chemotherapy in aggressive hormone receptor positive HER2 negative advanced breast cancer, with median overall survival of 24 months versus 12 months for the combination chemotherapy. Very impressive. Time to treatment response and objective response rate, and this is very important. We are dealing with a patient with aggressive disease, with the rapidly progressive symptomatic, so we need to know if the use of the endocrine treatment will be equal to the combination chemotherapy relieving such symptoms at the same time. And it has been shown that the ribociclib plus the endocrine treatment showed that the improvement of type 2 treatment of clinical benefit rate in the 66% versus 60%. This is the overall response rate, and the clinical benefit rate of 80% versus 72% for the combination chemotherapy. And median time to treatment relapse with the ribociclib and endocrine treatment was similar with combination treatment, time to response. So the time to response is about the 4.9 month, and for ribociclib and 3.2 for the combination treatment. So you need a very rapid active drug to control the disease. It was equal between the hormonal treatment and the chemotherapy, and the overall response rate and the clinical benefit rate were comparable between both lines of the treatment. Also, time to treatment failure and 3-month treatment failure was the higher for the ribociclib and the endocrine treatment when compared with the combination chemotherapy. Also, the use of the ribociclib and the endocrine treatment showed the benefit again more in younger patients than in the older patients. The reduction in the disease progression was higher among the patients younger than 40 years, with median progression-free survival not reached versus 10 months for the combination chemotherapy. There is also benefit in the older patients, but the benefit is not that pronounced as in the younger patients. Also, the same applied for the overall response rate and the clinical benefit rate. For the safety profile, the safety was consistent with MONALEESA trials. Nothing is more for this subset of patients, and the grade 3 toxicity in the hormonal treatment was only 1 versus the 7% for the combination chemotherapy. Of course, the treatment-related the grade 3 toxicity was higher among the combination chemotherapy. Safe drug. So now we're having an effective endocrine treatment for patients who suffered from the progressive disease with the effect in the duration which is equal to that obtained by the combination chemotherapy, and the higher progression-free survival and better safety profile. Waiting for, of course, the updated analysis. Now, for the endocrine resistance, and this is a big problem for the workers in the field of breast cancer. Primary endocrine resistance, as we all know, the definition is the relapse within the first 2 years of adjuvant endocrine treatment, or progressive disease within the first 6 months of the first line endocrine treatment for advanced breast cancer, while the patient is on endocrine treatment. For the secondary or acquired endocrine resistance, relapse while on adjuvant endocrine treatment after the first 2 years, or relapse within 12 months of completing adjuvant treatment, or progressive disease more than equal 6 months after initiating endocrine treatment. Of course, endocrine resistant is against this, meaning the relapse after 12 months of completing adjuvant treatment. These are the trials, including the endocrine sensitive disease only, MONARCH 3, PALOMA 2, and MONALEESA 2, while the endocrine resistance primary and acquired in MONARCH 2 and PALOMA 3 and the other MONALEESA 7 and 3 included the both subgroups, endocrine resistant and endocrine sensitive. In the PALOMA 3 trial, there is a significant improvement in the overall survival for the patients who presented with endocrine sensitive, but not in the patients with endocrine resistant disease. In the MONARCH, there is the improvement overall survival with the patients with primary endocrine resistance and secondary endocrine resistance, and the same applies for the MONALEESA for the ribociclib, where there is significant improvement in the overall survival among the patients with endocrine resistance and endocrine sensitive disease. Now, the impact of CDK4/6 inhibitors on quality of life and safety, which is very important for patients with advanced disease. This is the first line trial, the toxicity. We all know that the toxicity for palbociclib and the ribociclib are the hematological toxicity with the leukemia, while the main toxicity of the abemaciclib is the diarrhea. The adverse events occurring with ribociclib are usually asymptomatic, tend to occur early and decrease over time. So starting with most of the side effects are usually observed with the beginning of the treatment, and these usually decrease with the time as the patient is on the treatment, and the neutropenia leading to discontinuation of general discontinuation of the treatment less than 1% of patients, 4% for the inhibition of the liver enzymes, and the QT prolongation less than 1% of the patients require permanent discontinuation of the treatment. Across all the Mona Lisa trials, ribociclib-based combinations induced rapid and sustained reduction in pain, and this is very important for patients with advanced disease. This is the summary of the quality of life from the 3 trials of the CDK4/6, and as you can see in the Mona Lisa trial, there is always the improvement in the health-related quality of life with the significant reduction in the pain related to disease. Across the Mona Lisa trials, addition of ribociclib lead to maintained or improved overall survival. In Mona Lisa 2 and 3, among the post-exposure patients, there is maintained health-related quality of life, while in the Mona Lisa 7 for young patients, there is improvement in the health quality of life compared to the only endocrine treatment. Now, the question that has been asked, what after the progression on the CDK4/6 inhibitors? We have 3 CDK4/6 inhibitors, and the fact that they are the same drug, they are not, they are different in the pharmacokinetics and pharmacodynamics, and even in the outcome of the treatment. So it comes with to the surface what have, if there is any room for CDK4/6 inhibitors after progression, and this is the phase 2 maintain trial, addition of ribociclib to endocrine treatment after progression on the CDK4/6 inhibitors plus endocrine. Men or women aged more than 18 years of age with hormone receptor positive, more than equal 1% in the score, HER2 negative metastatic breast cancer with progression in endocrine treatment, and any CDK4/6 less than equal 1 prior line of chemotherapy for metastatic, meaning population not receiving chemotherapy or 1 line is only allowed. Measurable or non-measurable disease with good performance status and LHRH allowed for premenopausal women, and the stable premetastasis is allowed for inclusion, and the patients were randomized to receive either ribociclib and they switched the type of the hormonal treatment, not the same hormonal treatment given upon progression versus the placebo, and again switched to endocrine treatment. Fulvestrant as endocrine treatment if progression on the aromatase inhibitor for metastatic breast cancer, and no prior fulvestrant. Protocol amended to allow exemestane as endocrine treatment if progression on fulvestrant. So we can use either fulvestrant on the AI progression or exemestane if progression on fulvestrant. And these are the patient characteristics, where about the 78% of patients were previously treated with valprocycline and endocrine treatment, and there is the improvement in the progression-free survival by about 3 months for the re-challenge with the CDK4/6 ribociclib upon progression and only switching the hormonal treatment. However, this point is still under investigations, and there are still some trials trying to answer this question. CDK4/6 could be beneficial after the progression on the previous treatment. This trial with the valprocyclib and the immune therapy, with addition to immune therapy, and the Permira post-Mark trials. Now, this is the NCCN guidelines for the treatment of advanced breast cancer. It summarizes all what I have seen already about half an hour. For a first-line therapy, and when aromatase inhibitor is considered to be added to the CDK4/6 inhibitors, the guidelines say we have to use ribociclib as category 1, and this based on the outcome or the results of the Mona Lisa 2 trial. And if the fulvestrant is added to the CDK4/6, then you can use either ribociclib or abemaciclib, and this is category 1. For the subsequent treatment of patients after progression or as a second line, if the patient did not receive CDK4/6 in the first line, then you can use the hormonal treatment plus any of the CDK4/6 inhibitors. I just want to end my presentation with this post, and it's taken from Professor Fatima Kodozo. We all know about her, and she's an eminent figure in the advanced breast cancer, and now saying that the key objective of the advanced breast cancer conferences is to double the survival among patients with advanced breast cancer by 2025. And this is starting to happen. We have made a major step towards our goal of doubling average survival times for patients, because we have now achieved this in 2 or 3 subtypes of advanced breast cancer: the HER2 overexpressing, the HER2 positive, and the hormone receptor positive. The reported She said that the improvement in the overall survival has been reported recently by the HR positive advanced breast cancer treated with cyclin-dependent kinase 4/6 inhibitor at ESMO Congress 2021. First-line treatment with ribociclib plus letrozole led to median overall survival of 63.9 months compared with 51 months with letrozole only, 34% reduction in the risk, and we now have a median overall survival of 5 years. For the first time, we can speak about hope for these patients, not just wishful thinking. That's all we need, is that we hope and better outcome for our patients. Thank you for your patience and
Thank you, Dr. Amani, for this informative lecture. And now the last talk in this session will be by Dr. Ahmed Magdi, the story behind HER2 low disease.
So, good afternoon, everybody. I know you're all tired, but I promise I will not take long. First of all, I would like to thank AstraZeneca for allowing me to be their speaker today. So, I'm going to tell you the story of HER2 low. Is there a story? Let's see. This is my disclosure for today. This is the agenda. And let's go about the expression of HER2. It was discovered that almost every cell in our body has HER2 in different concentrations. And then actually, it was discovered that most breast cancers, they do have HER2 overexpression, even in the triple-negative breast cancer. And then it was correlated that HER2 positive patients do have poor prognosis, as published before in 1987, which is a very old study, showing us that HER2 overexpression is a bad prognostic index for breast cancer. Then again, it was discovered, and it was published again in 2021, that 55% of breast cancer are HER2 low. So what we thought before they were HER2 negative, 55% are HER2 low. Actually, they are more common in luminal breast cancer rather than triple-negative breast cancer. So what we got the idea is that triple-negative breast cancer, we should use the ADCs with them and find HER2. But actually, it is more with luminal subtype of breast cancer. And actually, they do have better overall survival. Better survival. And definitely, immunohistochemistry 2+ is worse than the 1+. And then we all heard about, and we all know by heart, how the anti-HER2 or the trastuzumab have been working. So if you see the HER2 receptors, they are activated either by the binding of the protein that stimulates their activation or by heterodimerization with the underlying or the side-lying HER2 group. Then this is why we have been using the trastuzumab and the pertuzumab in combination, which show the overall survival, whether in the adjuvant pathological CR or the metastatic. And then we all know these are all the HER2 approved by the FDA. But then the HER2 negative, this was the chart before. Most of our patients were HER2 negative. But then again, we overlooked a +1 or the low membrane staining +1 and +2. Then it was discovered, again, the association with the estrogen receptor. So luminal patients, they tend to have more HER2 low expression. But then came the dilemma, how to define HER2 low? So is it a static definition or a dynamic definition? So static definition is very simple. Those with HER2 +1 or HER2 +2, they are HER2 low. But what about your patient when you start with him as HER2 +1, and then upon progression, you get HER2 negative, 0, and then when you take another biopsy upon progression, he becomes or she becomes HER2 +1 or HER2 +2. So would you go with the static definition or the dynamic definition? Again, this is a very difficult question to answer. But then when we go to the NSABP famous trial that utilized the trastuzumab, if you look at the subgroup analysis, you find that HER2 negative were included and actually they were responding. So they started thinking, how on earth with HER2 negative the patients were responding? And then if you look at the trials of the TDM1, TDM1 actually had some activity if you look at the low curve with the HER2 negative. Yes, it was the poorer progression-free survival, yet there was some sort of a response. So before we used to say HER2 negative, and then HER2 positive, then HER2 low. And actually, I would like to tell you that we're now facing the ultra low in the future. And I will give you a hint about that. What about the trastuzumab deruxtecan we've been hearing about? So it's an antibody drug conjugate, and the idea has been explained marvelously by colleagues. But if we compare the trastuzumab deruxtecan with the famous TDM1 that we have been using for a long time. So the payload, which is the chemotherapy payload with the link to the antibody, is anti-microtubule in the TDM1. However, it's a 2-coisoprene inhibitor for the trastuzumab deruxtecan. And actually, if you look at the drug-to-antibody ratio, meaning the concentration of the chemotherapy linked to the antibody, it's 8:1 in the trastuzumab deruxtecan versus 3.5:1 for the TDM1. And actually, the idea behind the ADCs is mainly the payload and not the antibody itself, because HER2 is present, right? So it's, why the difference between the TDM1 and the TDXT? Because the payload is higher, the payload is more active. And actually, the tumor selective clinical linker is, yes, mainly with the TDXT versus the TDM1. And then we discovered, as Professor Ahmed Bostawisi showed us, that the bystander effect actually is a new modality of response. So when we give the antibody, it gets internalized, releasing the payload. Then when the cell dies, this payload actually transfers to the siding cell. So actually it kills the targeted cell and the bystander or the cell beside it. So if we look at the DESTINY-4 trial comparing the trastuzumab deruxtecan versus physician's choice of chemotherapy, as you can see for the separation of the curve, for the progression-free survival in hormone receptor positive patients, you'll see the beautiful separation of the curve. Actually, if you look here, you'll find the early separation of the curves. So you get an early response, an early separation of the curves. And this is in hormone receptor positive patients with an impressive hazard ratio of 0.5, meaning that 49% of your patient will achieve this response. And if you look at all patients, though hormone receptor positive or hormone receptor negative, you'll find again this hazard ratio is still maintained at 0.5 with again early separation of the curve. What about overall survival? I don't need to talk because you can see that you have gained almost 8 months of overall survival, 7 months of overall survival, and still a hazard ratio of 0.64. Again, in all patients the same. What about the progression in hormone receptor negative, specifically the triple negative, as you want to say? You'll find that the hazard ratio is even better with a hazard ratio of 0.46. Again, early separation. What about this waterfall plot curve? You can see that the change of size, you'll find it way more with the trastuzumab deruxtecan versus the chemotherapy. If you go through all the subgroup analysis, all were in favor of the TDXT. Progression-free survival and overall survival. What about if those patients with hormone receptor positive? Because we mentioned that HER2 low is mainly more with the human subtype. So definitely this lady has received the CDK4/6 inhibitor. Would this affect the outcome after the TDXT? Actually, no. For the progression-free survival, for those who received CDK4/6, they were actually better with the TDXT versus the chemotherapy. Even with no prior CDK4/6, you still get a benefit. So whether you put it before the CDK4/6 or after the CDK4/6, you definitely get a better response. What about those who received one prior line of chemotherapy? The response is still maintained. 1 or 2 or more, you get still a better progression-free survival. What about immunohistochemistry +1? As you can see, the hazard ratio of 0.47, meaning that 53% of your patients will achieve a response with the TDXT, and again, hazard ratio of 0.54 with IC2. What about the pipelines? We have the Destiny 8 trial combining the TDXD with multiple lines of chemotherapy. And if you look closely, second R here, you will find with the durvalumab, which is an immune checkpoint inhibitor and PD-L1. So basically, we are seeing in the future a combination, and maybe we can find a better outcome if we can go for that. And this is the waterfall plot for the combination. It was a phase 1b2, the combination of durvalumab with the trastuzumab deruxtecan, and you can see the decrease in the size is impressive. What about the neoadjuvant? We do have an ongoing neoadjuvant using AI with trastuzumab deruxtecan, but we don't have any data yet. And don't forget, we do have in the pipeline many antibody drug conjugates regarding the HER2 low, like the SYD985 and the datopotamab as shown before. What about the sacituzumab govitecan? When they showed us the data of the sacituzumab govitecan, which is an anti-TROP2, it was in the triple-negative patients. However, it included those what we used to call triple-negative, which HER2 low. So now you are facing the dilemma. For those HER2 low, should I go for sacituzumab govitecan or should I go for the trastuzumab deruxtecan? Time will tell us. We don't know this answer yet. So what about the ultra low? We heard about the ultra low. There is the ongoing trial Destiny Breast 06. So at 1+, we used to say low, right? But then they discovered the subgroup where it is positive between 0 and less than 1+. So these are the ultra low, and there are ongoing trials for that. So if we look at the most recent NCCN guidelines, you'll find that hormone receptor positive, HER2 negative, you get trastuzumab deruxtecan as category 1, sacituzumab govitecan also as category 1, and for now we don't know how to put them in sequence. If you look at the triple negative, if you get the BRCA mutation, you all know that you should use the olaparib, sacituzumab, and again, if you find HER2 1+ or 2+, you are allowed to use the trastuzumab deruxtecan. And to conclude, we now know that triple negative is not one disease, it's now a heterogeneous disease actually. And we cannot go and say triple negative as an absolute factor. We should look for the HER2 low because we now have target for them. And more data is very important needed to how to sequence our weapons that are present in the triple negative patients. And ultra low actually could be a very promising target in cancer. And thank you so much for listening.
Thank you so much, Dr. Ahmed, for the very elegant, informative presentation. Thank you so much for the speakers and for the chairmen. Can we allow questions or out of time? Okay, since we are out of time, thanks, Dr. Amani, for inviting me today in this very elegant conference. And now we will go to the next session.